Thank you, Bruce, for that very kind introduction. I'd also like to thank the CF Foundation for this great honor. And I'd like to thank John Engelhardt for sharing the symposium with me. I'd also like to take this opportunity to thank every child, parent, and adult with CF who has allowed me to learn about their CF-related diabetes to improve the lives of other individuals with CF-related diabetes. I first want to acknowledge that as a pediatric endocrinologist, that my perspective on CF-related diabetes may be slightly different than many members of the audience. And I want you to think about that as you consider these two messages that I'd like for you to take through this, this presentation. First, insulin secretion defects are present early in CF and are progressive. And secondly, understanding the mechanisms underlying defective insulin secretion may permit development of interventions that interrupt progression to diabetes. And Dr. John Engelhardt today will elaborate on some of the mechanisms beyond what I will talk about today. So first, why is CF-related diabetes so important? It's common. It first begins to make its appearance in mid-childhood, and then during adolescence and puberty, a time of maximal insulin resistance, we see the incidence of CF-related diabetes increasing. And estimates are that of adults age 30 and older, 40 to 50% will have CF-related diabetes. There is no other disease entity of which I'm aware that is associated with such a high prevalence of diabetes. But not only is diabetes common, it's also associated with pretty significant medical outcomes for individuals with CF. And I'm not here to discuss all those associations, but wanted to take this in particular study to illustrate some of the important aspects of CF-related diabetes. In this study that was conducted over a 25-year period, 200 children and adults with CF underwent serial oral glucose tolerance tests. And then survival rates and rates of lung transplantation were examined. Before I present the data, what I wanted to highlight, though, is that this study was conducted in an era in which CF-related diabetes, in the absence of hyperglycemia, was not traditionally performed. And these results may not be generalizable to our current CF-related diabetes population, in whom we are much more aggressive about managing their hyperglycemia. Individuals were divided into two groups: those who had early onset CF-related diabetes, i.e. less than age 18, and those who acquired their CF-related diabetes beyond that age. And those who had CF-related diabetes with earlier onset had lower rates of survival and increased rates of lung transplantation. Now, if you look at this data a little bit differently and examine it for when the individuals developed impaired glucose tolerance, and for those of you who are not familiar with that, impaired glucose tolerance predates CF-related diabetes. It's a precursor to CF-related diabetes. It's associated with less abnormal glucoses and more mild insulin deficiency. And again, if you look at those individuals who develop impaired glucose tolerance earlier, they as well have lower rates of survival as well as higher rates of lung transplantation. And this highlights for me the potential importance of those early insulin secretion abnormalities and those early glucose defects. We cannot neglect that CF-related diabetes can also negatively impact quality of life. We are adding another very burdensome chronic disease into the lives of individuals with CF who already do a lot of work for their medical care. It requires multiple blood glucose checks a day, and if the individual is not on an insulin pump, multiple insulin injections daily. And we also wanted to consider the psychological burden, and this is a quote from an adult with CF-related diabetes that I think really hones in on that issue. It was something that you didn't want to accept because it's an acceptance of the disease progressing. I had to wrestle with the fact that it was a progression of my CF. People deal with their CF-related diabetes differently, and obviously reactions vary and maybe come in unexpected packages. And a parent of one of my teenage girls, whom I saw a few weeks ago, and who actually has great diabetes control, the parent said to me, she takes better care of her diabetes than her CF. And I suspect that her CF team won't be too happy about that. Okay. But let me put a face to CF-related diabetes. This is Jeffrey. And his CF team referred him to me for an abnormal glucose tolerance test. And he experienced a decline in his BMI over about a 1.5 year period. And this decline occurred despite an adjustment in his pancreatic enzyme replacement, an increase in his daytime nutritional supplementation, and an increase in his frequency of overnight enteral feeds from a few days a week to nightly. Concomitant with this decline in BMI, he also experienced a decline in his pulmonary function. And in general, his FEV1 had been running around 105%. And over about a year's time, his FEV1 declined from 100% to 95%. Uh-oh. Sorry, I didn't expect that to happen. As is recommended by the CF Foundation, Jeffrey underwent an oral glucose tolerance test. And for those few of you who may not be familiar with those guidelines, annual oral glucose tolerance testing is recommended starting by age 10 in all individuals with CF who aren't already diagnosed with CF-related diabetes. And this is to screen and diagnose CF-related diabetes. And in order to do this test, the individual fasts overnight, and then a plasma glucose is obtained in the fasting state. The individual drinks a dextrose-containing drink over about 5 minutes, and a plasma glucose is obtained again at 2 hours. And that 2-hour plasma glucose is used to define the glucose intolerance state. Many of us also obtain a plasma glucose at 1 hour. Normal glucose tolerance, the plasma glucose is less than 140. Impaired glucose tolerance, that glucose ranges between 140 and 199. And CFRD is a plasma glucose greater than 200 during the oral glucose tolerance test. And some individuals with CF-related diabetes will also have fasting hyperglycemia. This tends to be a later manifestation of the CF-related diabetes and is representative of a severe insulin deficiency. Here are the categories in tabular form, but what I wanted to highlight is that in 2010, the CF Foundation introduced a new glucose intolerance category, which they refer to as indeterminate glucose tolerance. And this sought to recognize that there are glucose abnormalities and insulin secretion defects that occur even before impaired glucose tolerance. And here is a graph of an indeterminate glucose tolerance test. Blood glucose is greater than 200 at 1 hour. And then there's sufficient insulin secretion that glucose normalizes by 2 hours. The criteria for indeterminate is a blood glucose greater than 100 greater than 200 at 1 hour. I should share with you that in the non-CF literature, there is some data to suggest that a 1 hour glucose greater than 150 or 155 during the oral glucose tolerance test is also likely not normal, and at least in these non-CF populations may be associated with increased cardiovascular risk. So what do these insulin secretion abnormalities look like? These are tracings of individuals who underwent continuous glucose monitoring. And for those of you who are not familiar with that technology, a catheter is placed subcutaneously, and that allows glucose to be measured every 5 minutes. Individuals are sent home, and the glucose can be monitored for a several-day period. And not unexpectedly, an individual with CF-related diabetes has frequent glucoses greater than 200 postprandially. But what's not expected is that in individuals defined as having normal glucose tolerance, over a third of them will have glucose excursions greater than 200, and some approaching diabetes. And this is evidence, I think, that insulin secretion defects are evident even in the setting of normal glucose tolerance. So back to our patient. Jeffrey underwent 3 oral glucose tolerance tests over a 5-year period. At age 9.5 and 12, he had normal glucose tolerance as defined by a plasma glucose at 2 hours less than 140. A few days before he saw me, his oral glucose tolerance test was consistent with impaired glucose tolerance with a 2-hour plasma glucose of 194, less than 200, but greater than 140. But I would submit to you that his plasma glucoses at 9.5 and 12 were not completely normal. And that is a representation of, even in the setting of these quote unquote early insulin secretion defects, that there is evidence of progression. And I think an important clinical question is here that, is there a way to intervene to prevent this progression of insulin secretion defects and prevent the development of impaired glucose tolerance and CF-related diabetes? I just wanted to briefly review a normal insulin physiology for those of you who may not be familiar. When we ingest food, glucose increases. That increase in glucose stimulates pancreatic beta cell insulin secretion, and insulin has a number of jobs that are anabolic. Insulin suppresses hepatic glucose production. It stimulates glucose uptake by muscle and thereby promotes accrual of lean body mass. And it also increases glucose uptake by adipose tissue and suppresses fat breakdown. So all in all, insulin is considered quite a potent anabolic hormone. However, in the setting of insulin deficiency, as might occur in the setting of CF, a catabolic state can be evoked. And particularly in the setting of CF, this can compromise nutritional status. I also want to highlight, however, that beyond the impact upon nutrition, that there's some evidence that hyperglycemia directly negatively impacts both lung and immune function. One other piece of physiology that I wanted to share with you is that when one ingests food, and that food is properly digested, that those free fuels, namely glucose, fatty acids, and to a lesser extent amino acids, stimulate cells in the gut that we refer to as neuroendocrine cells. These neuroendocrine cells secrete hormones that we refer to as incretins, and those major incretins are GLP-1 and GIP. GLP-1 and GIP directly stimulate pancreatic beta cell insulin secretion. And in fact, they enhance normal glucose-stimulated insulin secretion. So you get even better insulin secretion in the face of incretin secretion. So you probably didn't think you'd hear about type 2 diabetes at the CF meeting, but I wanted to use type 2 diabetes as a model for how we might learn about CF-related diabetes. And in fact, many of us are borrowing the great advances in type 2 diabetes to better understand the mechanisms underlying insulin secretion defects in CF. So we generally think of type 2 diabetes as predominantly an issue of obesity and insulin resistance. But insulin deficiency underlies all forms of diabetes, including type 2 diabetes. And in the setting of type 2 diabetes, beta cells are no longer able to compensate sufficiently for the insulin resistant state. They perhaps undergo beta cell destruction as a result of stress from the hyperglycemia and perhaps inflammation. And there's also some data to suggest that an inherent beta cell defect does not allow beta cells to compensate significantly enough and allows for the development of type 2 diabetes. In CF, the traditional model has been one of collateral damage. Destruction from the exocrine pancreas flows over to that of the endocrine pancreas and destroys beta cells. But this does not appear to fully explain the insulin secretion defects and development of CF-related diabetes. And that data is primarily based upon autopsy studies. And so many of us have hypothesized that there may be, like in type 2 diabetes, an inherent beta cell defect. And beginning to borrow from that are some data on the genetics. And for any of you who are familiar with genome-wide association studies in diabetes, you'll know that polymorphisms in a gene called TCF7L2 are strongly associated with the development of type 2 diabetes. And they've been implicated in the insulin secretion aspect of type 2 diabetes versus the insulin-resistant aspects of type 2 diabetes. Scott Blackman has also identified that polymorphisms in TCF7L2 also increase the risk of CF-related diabetes, and that increases the risk of earlier age of CF-related diabetes. So I submit to you that I think that we can use type 2 diabetes as a model in some ways to better understand CF-related diabetes. And so Tony Moran, who's been a champion of CF-related diabetes care and research, in the early 90s began to explore what may be the underlying issue that leads to CF-related diabetes. And she performed oral glucose tolerance tests in individuals with pancreatic insufficient CF who did not have CF-related diabetes and measured their plasma glucose and C-peptide, which is a marker of insulin secretion. These individuals who do not have CF-related diabetes had early hyperglycemia. In addition, they were unable to mount the normal insulin secretion that occurs the first 30 minutes after ingestion of glucose, although they did have preserved beta cell insulin secretion later following the glucose tolerance test. And this is a very typical pattern in individuals with CF who do not have CF-related diabetes, this delayed and somewhat blunted insulin secretion. She looked at this a little bit further and performed what we refer to as intravenous glucose tolerance tests. So she gave a bolus of glucose at time 0. And then what I think you can appreciate is that compared to otherwise healthy controls, individuals with CF in the absence of CF-related diabetes have significantly blunted insulin secretion. And there's much evidence to say that this is not due to enhanced insulin sensitivity in the setting of CF. So they're not secreting less insulin because they use their insulin better. And so what I think I wanted to highlight here is that it's evident that in CF, even in the absence of CF-related diabetes, there's early insulin secretion defects. And Dr. Engelhardt will show you some of these similar studies that he's performed in his animal models in parallel to what I've shown you here. Our team wanted to interrogate pathways a little bit further. So be patient with me as I walk you through this somewhat complicated series of slides. I'm not going to go through all of glucose-stimulated insulin secretion, but I want to highlight that there are insulin secretory granules that sit at the surface of the beta cell, and they are readily available to be called upon for insulin secretion purposes. And if one gives an agent called arginine by an IV bolus, one can allow the beta cell to secrete all this insulin that's readily available. And that's shown here. This is referred to as an acute insulin response. If one now raises the blood sugar using a glucose clamp, and in this study to 230 milligrams per deciliter, even more secretory granules are recruited to the plasma membrane in order to secrete insulin. If one now gives arginine a second time, even more insulin secretion occurs. Now, if we raise the blood glucose to 340 milligrams to deciliter, even more insulin is made readily available for insulin secretion. We give arginine, and insulin secretion is even further enhanced. And these studies were conducted in red, healthy controls. We performed these same studies in individuals with CF, who by CF Foundation definition had normal glucose tolerance, plasma glucose less than 200 at 1 hour and plasma glucose less than 140 at 2 hours. At baseline, insulin secretion is normal. However, individuals with CF, even with normal glucose tolerance, are unable to mount the normal increase in insulin secretion compared to otherwise healthy controls. And this would suggest that there's a decreased capacity for beta cells to secrete insulin secretion. Now, part of this may be due to decreased beta cell mass as a result of pancreatic destruction. But we wanted to look at this a little bit differently. And so the question is there an inherent beta cell defect? And one of the defects that at least arises in type 2 diabetes is an inability to respond to glucose normally, meaning the beta cell is exposed to glucose but doesn't secrete insulin normally and requires a higher glucose in order to secrete insulin. And so one can define half maximal insulin secretion, right there. And then to define what the blood glucose is at which half maximal insulin secretion occurs. And we can do that for CEF as well. And there is no difference between the glucoses here. And so at least in individuals with normal glucose tolerance, there doesn't seem to be an altered sensitivity of the beta cell to glucose. So that doesn't seem to be the underlying problem here. And so we could look at some other pathways. And this was a very elegant study by Kuo et al. Published a few years ago. And I've introduced to you the concept of incretins, and incretins playing an important role in stimulating insulin secretion. And in this study, individuals with pancreatic insufficiency CF were fed a mixed meal, and then were given either enzymes or no enzymes. And what I would argue is that glucose excursion in the absence of enzymes is much worse. And so when you give pancreatic enzyme replacement, glucose excursion lessens. But it's not completely normalized. Not depicted well here is that insulin secretion also improves when you replace pancreatic enzymes. GLP-1 is near normalized in the presence of enzyme replacement compared to placebo. And GIP secretion is improved, but not normalized compared to otherwise healthy controls. So this would suggest that pancreatic exocrine insufficiency and maldigestion can contribute to not only defective incretin secretion, but insulin secretion and lead to hyperglycemia. I always recommend that my patients with glucose abnormalities, or I always advise them, like the CF team, that they should never forget to take their enzymes because it may have important implications for their glucose control. So another way that we might look at this is there an inherent beta cell defect related to Cftr. And there is some early data to suggest that Cftr is expressed to a low level in pancreatic beta cells and other cells of the islets. And so could Cftr be impacting insulin secretion at the level of the beta cell, or perhaps at the level of neuroendocrine cells? Or perhaps, as Dr. Scott Donaldson suggested in his plenary a few days ago, could alterations in bicarbonate in the intestine be directly affecting neuroendocrine function? And so Melina Bellin at University of Minnesota began to explore this. And she examined glucose intolerance as well as insulin secretion in 5 individuals who were started on ivacaftor. And they were treated for ivacaftor for 4 weeks. And they had variable degrees of glucose intolerance, including one with long-standing CF-related diabetes. And in that small study, she found variable improvements in glucose excursion and insulin secretion. So we wanted to tease this out a little bit more further to figure out where might ivacaftor be affecting these pathways. And so we're embarking upon a pilot study in which we will study insulin secretion during the glucose-potentiated arginine stimulation test, insulin and incretin secretion and glucose excursion during mixed meals, and prior to and following 16 weeks of ivacaftor. And we're hoping that this will provide some insight into the role of Cftr in insulin secretion and incretin secretion. So, back to our patient. I saw him a few days after this glucose tolerance test, and his hemoglobin A1C was 7.5. That is diagnostic of CF-related diabetes. Why his oral glucose tolerance test did not identify his CF-related diabetes isn't clear, but I think highlights some of the limitations of the glucose tolerance test. I also knew that he was on continuous enteral night feeds, and we admitted him to the hospital for insulin initiation and for education. And during his enteral feeds, he had frequent hyperglycemia to greater than 250. In addition, he had glucose excursions to 300 postprandially. And again, why the glucose tolerance test did not identify those significant abnormalities isn't clear. He was started on insulin, had a fantastic improvement in his BMI, hemoglobin A1C normalized, and his FEV1 improved from 95%, 100% to 105% within about 9 months. His pulmonologist shall remain nameless, but I will say he was jumping for joy. And Jeffrey's going about his life with CFRD. And his mom wanted me to share with you some thoughts. Caring for a child with CF-related diabetes can be challenging. Nutrition, medications, and treatments must be the most important part of your child's daily routine to ensure his or her well-being. As a parent of a child with CF, I feel we must help them build a positive outlook, stay active, and enjoy life. And I think this is the reason that this young man has done so well with his CF-related diabetes and continues to play baseball and football and do all those fantastic things, along as take care of his CF very well. So my goal as a pediatric endocrinologist and my tainted view that preserving beta cell function is a must is that I would hope that we could intervene and prevent hyperglycemia and insulin deficiency from contributing to worsening pulmonary function and nutritional status. And I also recognize that worsening pulmonary function and inflammation can contribute to hyperglycemia and insulin deficiency. And I like to halt those things. We have some ongoing challenges to achieve that goal. Screening can be a challenge. Many of us will admit to that. And many of us are looking at alternatives. I'm very aware of a number of centers looking at the use of continuous glucose monitoring to screen for and identify CF-related diabetes. The CF Foundation is funding 2 studies, a fellow study and a multi-center study to examine the use of the 50-gram glucose challenge test as a pre-screen for CF-related diabetes with the hope that this would improve adherence. This test is borrowed from screening for gestational diabetes, does not require fasting, only requires 1 blood glucose at 1 hour. And the objective is not to replace the oral glucose tolerance test, but to identify that subset of individuals who needs to go on to the formal 2-hour oral glucose tolerance test. So, other ongoing challenges. What is the role of earlier treatment? I get that question all the time. How might earlier treatment impact CF-relevant outcomes such as BMI, pulmonary function, and potentially survival? For me, what earlier intervention might we introduce to preserve beta cells? What would we use, insulin or preferably an oral agent? Arlene Shtasenko at Emory has taken up this challenge and is conducting a randomized control trial of a medication called sitagliptin. This is an oral agent that inhibits incretin breakdown and augments insulin secretion. And some of the things that she's looking at are pulmonary function, oxidative stress, as well as conversion to CF-related diabetes. Many of us are looking at mechanism. We're examining the impact of acute incretin infusion and chronic incretin-based therapy upon insulin secretion. John Engelhardt and Katie Odie at University of Iowa are looking at glucose excursion and insulin secretion in infants and toddlers with CF, and he'll share that data with you today. And then I think another important element that has really gone unaddressed are what are the environmental and lifestyle exposures that may hasten progression to CF-related diabetes. And at the risk of being thrown off this podium, what nutritional recommendations are we making that may hasten progression to CF-related diabetes? I think that's very relevant. So many questions remain. Animal models will hopefully provide additional insights into the mechanisms underlying insulin secretion, and Dr. Engelhardt will show those today. And again, what I want you to take home from this is that preserving residual beta cell function is an important consideration in the lives of individuals with CF. I'd like to thank the many people who have supported this work and wouldn't have been able to be conducted without this great team. I'd like to specifically acknowledge Mike Rickles, who has lent his expertise with the glucose-potentiated arginine stimulation tests, Chris Kubrak, who is a fabulous coordinator and recruiting patients, and Ron Rubenstein, who has breathed life into my vision to develop a CF-related diabetes program. Thank you.
Good morning. It's an honor for me to give this presentation. I'd like to thank Bruce for the kind introduction, and also Preston Bruce, Dr. Kelly, and Tony Moran for helping to mold this presentation. I have two disclosures. I consult for each of these entities. So Cftr is expressed in each of the organs listed here, and you've heard that 3 of these organs play an important role in regulating blood glucose. Now in humans, when Cftr is defective, each of these organs contract disease. However, in mice that are knocked out for Cftr, both the lung and the pancreas fails to develop disease, likely due to an alternative chloride channel that can compensate for Cftr. For these reasons, at Iowa, we generated Cftr knockout pigs and ferrets that contract both lung disease and pancreatic disease, as earlier described by Dorothy Anderson. The pancreatic disease is characterized by fat deposition, accumulation of mucus in the ducts, remodeling of the islets, as well as fibrosis. But newborn pigs and newborn knockout pigs and ferrets have very different pathologies at birth in the pancreas. The newborn pigs have inflammation and already exocrine destruction at birth, where the newborn ferrets have relatively minor histopathology and little inflammation. So newborn Cftr knockout pigs represent a later phase of pancreatic disease in CF, while the newborn knockout CF ferrets represent an earlier phase of disease. However, with time, within the first month, Cftr knockout ferrets rapidly develop inflammation as well as fibrosis, as indicated here in blue in sections of the pancreas. And this correlates with random excursions in blood glucose above 200 mg per deciliter, which would be considered significantly abnormal. These are 3 matched SIB pairs of ferrets over the first 3 months of life. And what you can see is that this CF animal begins to have blood glucose over 200 for about a month, arising at about a month of age, and this CF animal has it later. So there are phases very early in the disease that lead to spontaneous excursions in blood glucose following a meal. One can see that more clearly if one does a controlled defined study where we measured blood glucose before and 1 hour after feeding this SIB pair of CF and non-CF animals. And what you can see is that the CF animal that's in blue is born with fairly normal ability to regulate glucose. And then there's a very abnormal response following a meal that coincides with this onset of inflammation. And then a near normal, almost a recovery, where this animal can properly regulate its glucose following a meal, and then later returning to a normal state, which coincides with adipose tissue that I won't show depositing within the pancreas. So CF ferrets develop glycemic instability in phases that correlates with early pancreatic inflammation, fibrosis, and later remodeling. So as Dr. Kelly told us, there are a number of factors that can regulate insulin secretion and blood glucose. Following a meal, these hormones from the intestine, as well as glucose and fats, regulate responses of the islets that reside within the pancreas to secrete insulin. Now, there are 4 major endocrine cell types in the pancreas: a beta cell, alpha cell, delta cell, and a PP, or pancreatic polypeptide cell. And I'm going to be talking about each of the hormones that are secreted by these endocrine cell types that include glucagon, somatostatin, and pancreatic polypeptide that I'll refer to as PP. Now, each of these hormones, importantly, can either positively or negatively impact insulin secretion by the beta cell. So let's review how the beta cell responds to changes in blood glucose to secrete insulin. I'm going to be talking now about the first phase insulin that you heard from Dr. Kelly. Now, following a meal, glucose is taken up by a glucose transporter that then leads to ATP generation that blocks an ATP-sensitive potassium channel, depolarizes the plasma membrane, and leads to calcium influx that then leads to fusion of these granules that Dr. Kelly spoke of that are very close to the membrane in the beta cell. Now, second phase insulin secretion. is caused by a number of intracellular signaling pathways, some of which activate CFTR that I've marked here in pink. And this leads to a lower level of stable insulin secretion that maintains glucose at a steady state. So what are the hypotheses that can explain the pathogenesis of CFRD? Well, the simple hypothesis is what I refer to as the bystander hypothesis. This is a hypothesis where the exocrine pancreas gets destroyed and non-specifically takes out the endocrine pancreas. And it's true that there is islet remodeling in the CF pancreas at end of life, and this is true in both CF ferrets, pigs, as well as humans. An example here is from a CF patient in which you can see the islets look very different. These are stained for insulin in brown as compared to non-CF. However, most patients at end of life have about 50% beta cell mass, which is inconsistent with the abnormalities that they see in reduced insulin secretion and diabetes. The second hypothesis is the CFTR endocrine hypothesis. So this would propose that CFTR functions within an endocrine cell type within the islet. For example, the beta cell or the alpha cell directly influences insulin secretion. And then the third hypothesis, the endocrine extrinsic hypothesis, would propose that CFTR functions outside the pancreas or outside the islet, potentially the exocrine pancreas that's being destroyed, or potentially the gut, that CFTR functions there to influence the regulation of insulin by the beta cell. So we thought that using the knockout ferret model, which has relatively minor disease at birth, would be a good opportunity to ask the question of whether or not endocrine abnormalities exist before extensive pancreatic destruction and pathology. And so we performed oral glucose tolerance tests in newborn CF ferrets, and those plots are shown here, as you have seen from Dr. Kelly. And indeed, there's significant excursions in blood glucose that are different from the controls. This is just area under the curve showing that this is significant. And as well, the acute phase insulin secretion, the insulin secretion that occurs 2 minutes after glucose uptake, is significantly diminished in CF ferrets. This occurs despite the fact that both beta cell content and alpha cell content in the pancreas are indistinguishable between the CF and non-CF animals. So abnormalities in insulin secretion and glucose tolerance occur very early in CF ferrets. And it's the same for the CF pigs, and I won't be able to have time to show that data. But the impaired first phase insulin secretion is seen also very early in the ferrets, and it's also seen in patients with and without CFRD. But it's not known what this looks like early in CF infants. What was striking to us when we did these studies in the newborn CF knockout and control ferrets was not only the fact that they lacked this first phase insulin secretion, but the second phase insulin secretion was significantly accentuated. This is a log scale showing approximately a tenfold overshoot. This is much more significant than seen in older patients with CFRD. And so we asked the question how these ferrets regulate insulin and glucose when they're randomly feeding and nursing in the newborn neonatal period. Now, under non-fasting conditions, a positive relationship between insulin and glucose should exist in normal, such that high glucose gives rise to higher insulin. And indeed, we saw that relationship here with newborn non-CF animals, randomly sampled and nursing for blood glucose and insulin. There's a positive relationship that's significant in the controls. However, the opposite relationship occurred in the CF animals, such that at lower glucose, there was higher insulin and a negative slope on the log glucose to insulin plot. So this told us that late phase insulin secretion during this early neonatal period is significantly dysregulated. And although this is seen in CF patients, it hasn't been tested really early on in CF infants. And the relationship between blood glucose and insulin levels in the CF ferrets in that neonatal period is significantly disturbed, and again, not known in early CF patients. So where does the CFTR defect reside? Well, we've heard about the hormones that can regulate the pancreas and regulate insulin, and that CFTR is expressed in these organs, so potentially that could be one source. But the obvious question is CFTR in the islet, and is it directly regulating insulin secretion? Is there anything we can do about it? Now, our studies in trying to localize CFTR using null CF ferrets as a negative control. I'm showing here stains of a section with beta cells stained in red and CFTR in green. And you can see that the beta cells are predominantly negative, although there are some CFTR expressing cells that hang around the edge of the islet. And in human tissue, this appears to be similar. Very little CFTR expression in the beta cell, or it's undetectable expression by this method. However, we know if we isolate islets from CFTR knockout in wild-type animals, there is CFTR in the islet. It's fairly low, but it's detectable. So if CFTR is expressed in the beta cell, it's at extremely low levels. So using an alternative approach to ask if there are intrinsic defects in the islet, we asked the question of whether or not isolated islets for newborn CF and non-CF ferrets had altered glucose-dependent insulin secretion. And so we performed the following experiment in which we isolated islets from CF and non-CF, exposed them to low or high glucose, and asked how much insulin secretion is secreted over the course of an hour. This is the percent insulin secreted over an hour of the entire islet. And in non-CF ferrets, when one stimulates with high glucose, one sees increased insulin secretion. This makes sense. This is normal. However, in the CF islets, there was high levels of insulin secretion at low glucose and very little stimulation in the presence of higher glucose. Now, there are a number of reasons that this could occur. One of the obvious ones might be that the beta cells were just damaged and leaking insulin. And so we did the following control experiment to prove to ourselves that insulin was still controlled by the channels under the proper regulatory fashion. And so we treated CF islets with a compound called diazoxide. What this does is reactivates the K-ATP channel and repolarizes the plasma membrane and stops influx of calcium. This prevents fusion of the secretory vesicle with the membrane. And indeed, when we did this, diazoxide was able to completely block this hypersecretion at low glucose in the CF islets, suggesting that defects that are controlling glucose responsiveness of insulin reside upstream to this K-ATP channel. Now, interestingly, this inability to properly regulate insulin when the islet is taken out of the body, away from all the other hormones that may be able to control it, correlates with the inability of these randomly fed newborn CF ferrets to properly regulate their insulin. You can see right here, these are insulin levels very broadly scattered over a very wide range as compared to the controls. So dysregulated insulin secretion in CF, at least in part, appears to be islet intrinsic. And does CFTR insulin secretion affect, or does CFTR influence insulin secretion in other species? So we did the following experiments. Now comparing, I'm just changed the data to make it slightly easier to look at. We're going to be looking at the Secretory Index, which is the percent of insulin secreted at high glucose divided by the amount at low glucose. This is an index of the glucose responsiveness of the islets. And you can see in ferrets and pigs, both are less responsive to glucose, secrete less insulin when challenged with high glucose. And we performed alternative experiments where we took adult islets and, from CF ferrets as well as humans, created a method to knock down mRNA within these islets, and create a CF-like islet by which to test the same hypothesis. And this is just showing the ability to knock down CFTR in both these species using cell lines. And indeed, in both of these cases, ferret and human, knocking down CFTR reduces the glucose responsiveness of the islet to secrete insulin. So indeed, disruption of CFTR in the islet impairs glucose responsiveness in each of these species. So what else can these CF models tell us about the pathogenesis of CFRD? Well, I want to show you a case study of a ferret that we followed over a time course performing mixed meal tolerance tests. And what I'm showing here are the glucoses of this animal at 50 to 200 days. And what you can see is that if one was to classify these according to oral glucose tolerance test classifications, this animal initiates would be classified as CFRD, and then becomes impaired glucose tolerance, and eventually indeterminate, which is less severe later in the timeline of this animal. And if one interrogates the hormonal changes, and I'm only showing you a few here, one sees that there are dynamic changes in GIP as well as pancreatic polypeptide at both the late and the early phases. Whether or not these are actually compensating for the lack of the ability of the islet to properly regulate insulin is unclear at this point, but certainly these hormonal changes would influence how the beta cell reacts to changes in glucose. So early glycemic and hormonal abnormalities in CF ferrets dynamically evolve over the first 30 weeks of life. And if one takes the averages of a number of animals in comparison with what I showed on the previous slide, using normal, these are oral glucose tolerance tests that would be typically used to diagnose patients, one sees that the younger ferrets are fairly normal, despite the fact that following a meal, they have very abnormal glucoses. However, eventually, the older animals progress to what would be classified as indeterminate glucose tolerance. These changes occur in the setting of changes in insulin secretion, and I won't be able to show the data, but this does not appear to be due to increased insulin resistance. If one interrogates using one of the tests Dr. Kelly told us about, an L-arginine tolerance test, this is sort of a test for the capacity of a endocrine cell to immediately secrete its primary hormone. And so for 4 different types of endocrine cells, we have alpha, beta, PP, and delta cells. Each of the major hormones, including glucagon, somatostatin, pancreatic polypeptide, and insulin, have decreased responses acutely immediately following L-arginine. So early abnormalities in oral glucose tolerance are accompanied by perturbations in multiple hormones that also respond to changes in blood glucose. And there are defects in L-arginine responses in each of the major endocrine cell types, suggesting that the defect in the inability to regulate these hormones is quite global. So why is this potentially important? Well, there are many activating and inhibitory inputs that regulate how the beta cell secretes insulin. Defects in any one of these pathways would lead to counterbalancing adjustments in pathways that attempt to correct for that. And how these lead to the ultimate degradation of the beta cell in CFRD is presently unclear. But the evidence does suggest that early abnormalities in the regulation of hormones that act on the beta cell may be responsible for abnormal regulation of insulin. So what phases are we studying in the ferret model for the data that I've shown you so far? Well, if one makes the analogy that humans live about 75 years and ferrets live about 11 years, and one normalizes this over the course, currently all we've studied in the ferrets thus far are about the first 270 days. This is equivalent to approximately 5 years in humans. And if one looks at the various age phases and summarizes the data for insulin secretion, one sees at birth there's significantly accentuated insulin secretion. This is despite the fact that there is no hepatic insulin resistance that we can tell of. Then there's this intermediate period where insulin tends to respond normally, and then a later period where again there's insulin hypersecretion. If one compares this to the pigs, that if you recall at birth, the pigs are born with more extensive disease. They have, if anything, a less of an ability to secrete insulin in response to glucose, modeling the later phases of the disease. So in contrast to later phases of disease, early abnormalities that accompany glycemic instability in CF ferrets are not due to the lack of insulin, but rather poorly regulated insulin and hormones that control insulin. So do these abnormalities exist in CF young children? We initiated a clinical trial to try to address some of these questions, in which we looked at 3 to 5 month 3-month to 5-year-old children. They were given oral glucose tolerance tests, and the data that I'm going to show you include these hormones as well as some other not listed here, and primarily looking at area under the curve in order to compare perturbations in these hormones. And what was seen in just summarizing in 2 different age classes, and we don't have a lot of controls yet, so most of the comparisons I'm going to make are between abnormal and normal glucose tolerance in CF kids. But what you can see is that the glucose profile here is generally much higher and abnormal for kids that are greater than 2 years old as compared to kids that are 2 or the 2 normals that we have. And again, insulin in these abnormal glucose tolerant kids is generally higher, as one might expect, because it's compensating for higher glucose. We were surprised somewhat that 42% of the 12 children that were between the 1 and 5 age bracket demonstrated abnormalities in glucose tolerance. And right here I've just summarized the classifications of these, showing the glucose profile and their insulin profiles, which are significantly abnormal when one compares them to kids that have normal glucose tolerance and are less than 2 years old. And if one interrogates all the hormones that I've been talking about in the ferret model, one sees that there are some significant similarities and changes between abnormal glucose tolerance and normal in the CF kids that would reflect wild type to CF comparisons in the ferret, including pancreatic polypeptide. C-peptide is a marker for insulin and insulin. So as with CF ferrets, early glycemic abnormalities are not a consequence of the lack of insulin, but rather poorly regulated insulin secretion and potentially insulin action. This is just to compare some of these comparisons between, or to show some of the comparisons between the ferret and abnormal and normal glucose tolerance kids. We see again insulin overshoot and a lack of pancreatic polypeptide secretion in the CF ferrets, and a trend towards lowering pancreatic polypeptide secretion in the abnormal glucose tolerance kids. So what other changes in insulin-regulated hormones track with the maturation of abnormal glucose tolerance in CF? Well, I'll remind you that each of these hormones can positively and negatively regulate insulin. We took our data for each of the patients, area under the curve for each hormone, as well as area under the curve for glucose, and classified this in a normalized fashion and just color-coded here for low being blue, high being yellow, and intermediate black. And in this manner, each of these indices and hormones were given a block, which was a certain color that would reflect high or low in a normalized fashion. And so we did this for all of the CF patients, here hormones being in the columns and each patient being in the row. And if we ask a computer to do unsupervised hierarchical clustering, which will essentially say to the computer, try to match the patterns between area under the curve glucose and the various hormones that are changing, and order these in a fashion, this is what comes out. Again, hormones being each of the columns and each of the rows being patients, and this is area under the curve glucose. What was fascinating to me is that information we didn't give the computer, that this computer was able to line up very specifically the higher abnormal glucose tolerance group. These have higher area under the curve glucose. It matched perfectly with abnormal glucose tolerance with peak levels of glucose during the glucose tolerance test above 180. The normal glucose tolerance kids, here marked in blue, matched up with peak glucose is less than 140. And the intermediate group fell into this area here. Peak glucose is 140 to 180. And what was most fascinating was the fact that there were specific patterns that occurred, including the fact that the abnormal group had very high levels of these hormones, low of these, but the normal glucose tolerance group had the opposite pattern. And even more fascinating is the fact that the borderline group fell into a very unique pattern of hormones that were very different from either of these normal and abnormal groups. Insulin and pancreatic polypeptide fall there. Now, an endocrinologist in the audience would probably say, well, mostly the insulin and the glucose may drive this clustering that the computer's generating. And so we took out those values, regenerated the clustering, and the identical pattern was seen for both the abnormal glucose tolerance and intermediate glucose tolerance. The normal glucose tolerance still fell on the bottom. They're slightly different order, but they were still all in the same range. This suggested that really it was the distinct hormones patterns that were being able to predict the abnormal glucose tolerance in these kids. So while still very preliminary, it's interesting that the hormonal patterns appear to classify degrees of early glycemic abnormalities in CF. And just as interesting, if one looks at the fasted hormones, one also sees the distinct patterns that classify, interestingly, abnormal and borderline group that look similar, where all these hormones are very high in the normal group. PP and glucagon are there. So what does this mean for CF patients and for 14-year-old Jeffrey, who now has CF-related diabetes? Well, the one thing that we've learned from the ferrets is that the early maturation of the CFRD disease state is very plastic. This is also true to some extent in CF patients, where they can shift back and forth between various classifications of impaired glucose tolerance. This suggests that potentially tight nutritional control may be able to have a large impact on the progression of disease. Understanding the process as well of the maturation of this disease, the phases that are seen within the CF ferret model, may tell us what is changing in the pancreas and how it's remodeling, such that we can slow the progression of beta cell dysfunction. How about what's going on earlier in even younger kids? Well, potentially the hormonal disturbances that I've shown you, if these bear out in a larger study, may help to improve early diagnosis, finding those patients that are right at the borderline and intervening in a clinical way, either with nutritional therapies or other therapies, to slow the progression of disease. And additionally, the mechanistic studies that need to continue in the CF pig and ferret models may ultimately tell us what is the primary defect and how can we approach that therapeutically, either with hormone treatments or potentially drugs that target certain channels in some of these cell types, again leading to early intervention. So the mechanisms of CFRD and therapy will come from not just the regions that overlap between these models, but I strongly believe, just as the mouse has told us, that we learn a lot from the differences between these models as well. Now, I'd like to thank a number of people that were really critical to this study that occurs at 3 institutions and 8 faculty. Katie Larsen-Ody, who has headed up the clinical trial in collaboration with Tony Moran. She really so enthusiastic and surmounted a number of obstacles to get this off the ground, as well as Andy Norris, who is the pediatric endocrinologist, who is really keeps my feet on the ground and thinking going forward, as well as Leah Uch, who is very collaborative with the pig model, and we're doing a lot of studies back and forth. Alicia Olivier, head pathologist, and Lou Phillipson and Debbie Nelson, who have helped tremendously with a lot of the islet studies. I'd also like to thank NIDDK, who really took a chance to fund this team science project a year ago and has really taken off. Also, I'd like to thank members of my lab. Yeah, these guys are really cute. Bruce said to put this one in. Really, this is a tremendous project. Takes many, many people. I couldn't mention them all, but thank you to everybody who's here. Thank you very much.